Hi everyone, this video will talk about IV fluids in pediatrics in cases of hyponatremia. So hyponatremia is decreased sodium concentration. The normal sodium concentration is 135 to 145 millimole per liter. So a hyponatremia is when serum sodium is below 135 millimole per liter. So most children with sodium above 125 millimole per liter are asymptomatic. Okay, so no much symptoms show unless it gets lower. Hyponatremia and rapid fluid shifts can result in a cerebral edema, which causes neurological symptoms. Okay, so now when sodium is below 125, so we said above 125, no much symptoms. When it's below 125 millimole per liter, or if serum sodium has fallen rapidly, vague symptoms such as nausea and malaise are more likely and may progress. And if it's below 120 millimole per liter, we find headache, lethargy, obtundation, and seizures may occur. Obtundation is altered level of consciousness. Okay, as in hypernatremia, chronic hyponatremia, which happens over more than 24 hours, has subtle features. They're not very obvious. So patient may present with restlessness, weakness, fatigue, or irritability, and that is because of cerebral adaptation. The symptoms are not very severe. Okay, so rapid correction can result in osmotic demyelination syndrome. This syndrome manifests as irreversible neurologic features, such as these features are dysarthria, confusion, obtundation, which is altered mental level of consciousness, and coma, which often presents days after sodium correction. So it doesn't present right away. Okay. As for the causes of hyponatremia, they are divided into three sections. We've got the fluid overload, euvolemia, and dehydrated. So, sodium concentration and fluid overload. If we've got fluid overload, it means that sodium concentration will decrease. There are cases when there's euvolemia, which means that there's no change in the fluids are of normal levels, and there are cases with dehydration. So let's get into details with each one of them. So the first one is fluid overload. As we said, IV fluid administration in excess of the child's needs. That's why we said before in a previous video that we need to give 2/3 of the maintenance fluid. If we do give all of the maintenance fluid, it might cause hyponatremia. The second cause, so this one in bold, all the causes in bold are the common ones. Other causes for fluid overloaded hyponatremia are nephrotic syndrome, cirrhosis, heart failure, acute chronic renal failure, and obstructive uropathy. Now for euvolemic hyponatremia, administration of enteral hypotonic fluids, including dilute formula, oral rehydration solutions, and excessive water intake. The second cause is psychogenic polydipsia. The third is increased ADH secretion. We talked about increased ADH secretion in sick children, especially in pulmonary conditions, CNS conditions, and postoperatively and in trauma. So pulmonary in pneumonia, bronchiolitis, and mechanical ventilation, CNS in infection, injury, and tumor, and postoperatively trauma and pain. Also endocrine, there are endocrine causes of increased ADH secretion, which are hypothyroid and low cortisol. Medications can also lead to euvolemic hyponatremia, such as chemotherapy, cyclophosphamide, vincristine, platinum-based agents, Antiepileptics also can cause hyponatremia and vasopressin. Now, as for dehydration, GI losses and rehydration with free water. So we're always talking about decreased concentration of sodium. So we've got here GI losses and electrolytes losses, and the rehydration is with free water, so the sodium concentration is decreased. That happens in cases of gastroenteritis, secretory or osmotic diarrhea, or ostomies. Ostomies are artificial opening in an organ of the body, such as a colostomy, ileostomy, or gastrostomy. So this can also cause dehydration with hyponatremia. Skin losses, as in cystic fibrosis and burns, abdominal third spacing, high rate fluid consumption post-exercise, hyperglycemia, renal losses such as in thiazide, diuretics, and cerebral salt wasting, primary renal tubular disorders, and hypoaldosteronism and metabolic alkalosis. So these are this is just an overview. If you need any topic explained in details, please leave a comment below. Okay. So now we'll be moving on to assessment. The first thing we should do is check history, look for history consistent with common causes for hypovolemia, and history of fluid intake or losses. We should also do clinical assessment of the hydration status, neurological status, and bear in mind the red flags. So what are they? The first one is nausea and vomiting. The second one is irritability. The third one is headache. The fourth one is decreased conscious state. And lastly, seizures. Okay, so now let's move on to management. So we start with the investigations. So if sodium is below 130 millimole per liter, we might do some investigations such as the paired serum and urine osmolality, urinary sodium. We can also check the blood sugar level and consider blood gas if the patient is sick. As for prevention, special attention should be paid when prescribing fluids to children with conditions associated with increased ADH secretion. So what do? We only give isotonic fluid, which is 0.9 saline plus 5% glucose for maintenance. We only give half to 2/3 of maintenance if the child is euvolemic. We also do regular weight and measure urea electrolytes and creatinine at baseline, then monitor daily. As for treatment, the target rate of sodium correction is 6 to 8 millimole per liter per 24 hours, unless the patient is seizing. We also should remember to always treat the underlying cause. So this flow chart will help us with the treatment. So, do we have seizures or encephalopathy in the patient? If yes, then this is a medical emergency. We should contact the ICU urgently and give 3 to 5 ml per kg IV 3% saline, which is preferably given through a central line, over 15 to 30 minutes, and then we continue the seizure management. If you want the seizure management in details, please leave a comment below. Then we remeasure the urea electrolytes and creatinine, and we aim to correct the sodium by no more than 2 millimole per liter per hour in the first 3 to 4 hours. Okay, then seizures terminated or sodium above or equal to 125 millimole. If no, then we do the cycle again. We give 3 to 5 ml per kg IV 3% saline, and then remeasure urea electrolytes and creatinine, and then check again. If the seizure is terminated or the sodium is above or equal to 125 millimole per liter, then we should slow sodium correction over 48 hours including the hypertonic saline bolus. This should not exceed 12 millimole per liter in 24 hours. And then we keep measuring the urea electrolytes and creatinine 4-hourly until stable. So that's the part with seizures and encephalopathy. So if we don't have any seizures or encephalopathy, then we discuss with ICU if the sodium is below 125 millimole per liter. And then we assess the hydration. So active correction with 3% saline is not indicated and potentially harmful. So we don't do this step unless it's a medical emergency and we need rapid correction. And that's not the case if the person is not seizing or is not having an encephalopathy. Then we just give isotonic fluids. So we assess hydration. So we've got euvolemic or fluid overload, dehydrated with normal sodium, not normal but not so low, or dehydrated with sodium less than 100 or equal to 130. So in euvolemic or fluid overloaded, we restrict total fluid intake to half or 2/3 maintenance. And we use enteral feeding if possible. If IV, we only give isotonic solutions. So as we said, we give isotonic solutions. The preferable one is the 0.9% saline and 5% dextrose. Okay. If dehydrated and sodium is 130 to 134 millimole per liter, we can consider enteral rehydration with oral rehydration solution. Okay, and if dehydrated with sodium less or equal to 130, then we give IV isotonic fluid, which is, as I said, the most preferable one is 0.9% saline and 5% dextrose at full maintenance rate. So in this case, we give full maintenance because the patient is dehydrated. And then we measure sodium 4 to 6 hourly until sodium is above or equal to 125. So in each case of these, we keep monitoring the patient. We measure sodium levels at least 12 hourly if sodium is more or equal to 125 millimole per liter, and do not allow serum sodium to rise more than 8 millimole per liter in 24 hours. Remember, we don't have to correct. We should not correct the sodium at a rate more than 8 millimole per liter in 24 hours. Okay, and then we monitor ongoing for any CNS symptoms coming up. Alright? So some important notes are that the risk of morbidity from delayed treatment is greater than the risk of osmotic demyelination from an overly rapid correction. So remember, aggressive initial correction is indicated in the first 3 to 4 hours or until symptoms resolve at a rate not to exceed 2 millimole per liter per hour. So we should act fast, okay? The second thing is hyponatremic seizures may be refractory to anticonvulsants. So sodium correction should not be delayed. That's why we treat seizures due to hyponatremia aggressively at first. And remember that 3% saline should preferably be given via central line. So that's it for this video. Thank you so much for watching. Please like this video, subscribe, and share it with your friends. Also ring the bell so that you will get notifications whenever I upload a new video. Thank you so much.